hypertension is a continuous variable. That 110 is better than 120, that 100 is better than 110, and as long as the person does not have orthostatic symptoms. In other words, the risks associated with blood pressure are continuous. This is not dichotomous, but we are categorizing it because we have to have cutoffs. Okay? We cannot just deal with saying, I want to treat blood pressure at 100 and so forth, because we think that the benefits of treatment, there's a certain cutoff where we think the benefits of treatment outweigh the harms associated with treatment. So at stage 1 hypertension, this is now systolic blood pressure greater than 130 and diastolic blood pressure greater than 80. Okay, the target now is to try and keep the blood pressure below 130/80 in some instances. Now, in most instances. Now, the question is, when one is in that stage 1 hypertension, what is done? Are people to be treated with just non-pharmacologic measures, or do some people require pharmacologic measures as well as non-pharmacologic? So that is something I am going to talk about with you as we go on. In stage 2 hypertension, there's no question that people will need medications to be treated. Okay, that is if their systolic is greater than 140 or their diastolic is greater than 90. The tendency is to most people will need pharmacologic treatment. Now, how do we measure hypertension? This is not just one blood pressure reading. This is an average of at least 2 blood pressure readings in the office. Okay, so preferably more. If the blood pressure elevation is mild in stage 1 and the patient does not, we'll talk about meet criteria for immediate or treatment, then we have some time and you can initiate non-pharmacologic measures and keep getting these measurements over time so you're more confident that the patient has hypertension. What else did I want to say about? Also, it's very important to we're making a lot of clinical decisions based on a number. So it's very important that number should be collected properly. So I think would behoove everyone to read about proper method in taking blood pressure, where the patient is seated. Their arm, there's no tight garments on the arm. Okay, we don't take blood pressure over a coat or over a shirt. The arm should be bare. Okay, and it should not be constricted above it. Excuse me. The arm should be resting, that the blood pressure is going to be taken in should be resting at about heart level. The patient should ideally be relaxed and maybe seated for several minutes, not running into the office and immediately taking the blood pressure. The cuff size should be, which are specified in some of these guidelines, should be correct for the patient. There are very, very well specified cuff sizes and so forth. So again, this is not just based on one reading, this is an average and so forth. Sometimes the readings are not consistent, and it's very good to, we think, to have what we call home blood pressure monitoring. Many of the cuffs that are now used frequently correlate closely with blood pressures in the office, and patients can take their measurements at home, bring them in, and you can form a better judgment about whether the patient has hypertension or not, or stage 1 or stage 2, and also monitor the response to treatment. It also engages the patient in the process. So we think that there are very important advantages for home blood pressure monitoring if that is available. These are in the bottom right-hand corner of the slide, I mentioned that African Americans have a higher prevalence, and Asians have a slightly lower risk, but it's not really much lower, maybe a few percentage points, not really significant. It's pretty prevalent in all cultures. So the risk factors, as I said, hypertension increases with age. Weight is an important risk factor. Diabetes, we know. Physical inactivity, high sodium diet, high alcohol intake. Why might alcohol be associated with hypertension? And it's also resistance to treatment, because as alcohol is being metabolized, what is stimulated? What is stimulated to be secreted? But adrenaline. And therefore, high cardiac output, tachycardia, and so forth, and stimulation, etc., that lead to worsening of blood pressure. And smoking, the effect of nicotine, etc., and also vascular damage. All these factors are associated, behavioral risk factors. So this is a current classification system by severity. Okay. Did everybody get to see that? Yes, I hope. Okay. Now you can also classify it by what we call essential hypertension or secondary hypertension. Essential hypertension means we will not find a specific cause or disease or disease process or pathophysiologic state that accounts for the patient's hypertension. This is about 90 to 95% of hypertension. Most of the clinical trials that I might mention are based on people have studied people with what they call essential hypertension. However, you must be aware that in 5 to 10% of cases, there are specific causes or specific factors that may be amenable to intervention. Not necessarily, but they may be. Okay. So one of the more common types of secondary hypertension is what we call renal artery stenosis. Okay, where a stenosis, either through something we call fibromuscular hyperplasia, which occurs more in younger people, or atherosclerotic stenotic renal arteries from atherosclerosis, leads to decreased blood flow in the kidney and this is a stimulus for renin production and as a cause of hypertension. And so we suspect this in fibromuscular hyperplasia, where there's a beating. It's an abnormal, you can see it in if you can look at that radiograph, that arteriogram, where you see a beating pattern in a renal artery or its branches or an accessory renal artery that does affect the blood flow. And the usual person women are affected more than men. These are usually younger women in their 30s or early 40s, maybe mid 40s, who get this. They don't necessarily have other risk factors. A very important finding now the more common type of renal artery stenosis is from atherosclerosis, from narrowing, the same as in coronary artery disease, where the blood flow, when there's 80% or 90% narrowing of a renal artery, the blood flow is restricted, and the kidney sometimes loses function, becomes smaller. There's a difference in size, and secretes, and you have a high renin state from the decreased blood flow. Now, there are other causes as well. Okay, so we would consider, if people have heard of aldosterone-producing tumors, benign tumors in the adrenal gland that produce mineralocorticoid, that produce aldosterone, which leads to sodium retention and potassium excretion, and frequently one might see hypokalemia. This usually sometimes leads to severe hypertension, but more often than not, when people have aldosterone producing adenomas, which can be unilateral or bilateral, they have moderate hypertension and can be treated by addition of certain medications like aldosterone antagonists, such as aldactone or spironolactone, that help and sometimes just basically take care of the hypertension along with some of the other medications. Other forms of secondary hypertension include a tumor that secretes catecholamines, which is intermittent, called a pheochromocytoma, which is often incidentally discovered, but is associated with a certain symptom complex of episodic hypertension, palpitations with tachycardia, sweating, and headaches, because the tumor, the pheochromocytoma, secretes the catecholamines intermittently. Sometimes, and the hypertension that results can be severe because of just an outpouring of catecholamines into the circulation and can actually lead to a hypertensive emergency. Sometimes this occurs and the patient has never had these symptoms before. There was no reason to, they're not very common tumors, but after surgery, the patient has an outpouring of catecholamines, and this is discovered, and there's an emergency, which is totally unexpected. So that can happen. Other causes include hypercortisolism, like Cushing's disease or Cushing's syndrome, or exogenous steroids. Then there are conditions that are associated with this. Sleep apnea. When a person has obstructed breathing at night, they stop breathing, and sometimes associated with severe hypertension. If sleep apnea is considered as a possible diagnosis, it's might be useful to do ambulatory blood pressure monitoring or 24-hour blood pressure monitoring at home, if that is available, to see if the blood pressure rises significantly at night. Okay, so now in secondary hypertension, I think it's important to also look at medications the patient is taking and so forth, as you know, as non-steroidal anti-inflammatory drugs become sometimes a cause, what I would say is secondary hypertension, or a factor in a patient's marked elevation of blood pressure. All right, so we have hypertension classified by severity, elevated, stage 1, stage 2, and then we have essential versus secondary. Okay, here we go. Let's see what we've got here. All right, let's go. I'm going to go back. Now, when I said, when people are in stage 1 hypertension, stage 1, 120 to 129, I'm sorry, 130 to 139, 80 to 89. Some people, it's current recommendations are, some people, one can start with non-pharmacologic interventions. Who are those people? Those are people who have very low cardiac risk. They don't have, they're non-smokers. They don't have hyperlipidemia. They don't have already coronary artery disease. They don't have diabetes. Okay. They're not overweight. Okay. Those people, when they're decided they have stage 1 hypertension, one can work on their non-pharmacologic interventions, okay, such as exercise, changing their diet, modifying alcohol intake, actually eliminating if possible, stopping smoking. All these things will help, okay, if they're all right. And one can start this way with a time period of a few months to see if these interventions work. However, in people with stage 1 hypertension who have high cardiac risk, not necessarily that they already had a heart attack or a stroke, but that they're at risk for these things, then it's recommended that you do both non-pharmacologic and pharmacologic fairly soon, almost even initiating after the diagnosis is made, okay? So that the time element is not there. So how do you decide if somebody's at high cardiac risk? Well, there are risk predictor models, and there are the guidelines of the American Heart Association and so forth are to use a risk prediction model where the risk, a 10-year risk of a cardiac event is greater than 10%. For your purposes, I think you just need to know that people with stage 1 who are at high cardiac risk can start medications and non-pharmacologic therapy fairly soon in the treatment, even once the diagnosis is made, and that you can say pretty much any middle-aged person who has diabetes or is a smoker or is markedly overweight, where their BMI is significantly high, they are at high cardiac risk. Okay, you can pretty much assume that in middle-aged persons. But as you go on in your training, I think that you will probably, if this remains as a criteria, you will see reference to the cardiac risk indicator tool that people use, which looks at blood pressure, gender, prior history, cholesterol, and so forth. You plug it in for the individual patient, and it gives you a 10-year probability of developing a cardiac event and so forth. So I just want people to be aware of that. Now, in stage 2 hypertension, or in people whose blood pressure is felt to be, systolic blood pressure is felt to be 20 millimeters over target, or their diastolic blood pressure is 10 millimeters over target, and the average, let's say, of 2 or 3 or 4 readings, then some guidelines, I'm not saying, I don't know how I feel about this, but some guidelines recommend starting with a combination of medications. We'll talk about the medications that have really become at the fore in treatment of essential hypertension. But basically, the feeling is that these are people who are going to end up on 2 or 3 medications, so it's best to start them early and to start them with a combination pill that's easy to take and easy to be compliant, easier to be compliant with. Okay, so with stage 2 hypertension and people are 20 millimeters above target or 10 millimeters above target diastolic, 2 or more medications can be started at once. I've always used a stepwise approach, but these things have changed since I left practice. So just want you to know that things change. Let's go on. Let's go back to severe hypertension, severe acute hypertension, or hypertension, what I used to call hypertensive urgency or hypertensive emergency. All right. First of all, it's defined by the level of blood pressure. A systolic blood pressure of 180 or greater, okay, or a diastolic blood pressure of 120, excuse me, or greater is the level at which we become concerned about whether a person is having a hypertensive urgency or a hypertensive emergency, okay? What is the difference? Hypertensive emergency occurs when we see acute end organ damage that is occurring along with the markedly elevated blood pressure. And what do we mean by end organ damage? Well, the brain can be affected by stroke or by a diffuse syndrome called hypertensive encephalopathy, where a person becomes confused, they might have a seizure, they have headaches, okay? But confusion or a seizure in somebody with very high blood pressure must make you think of a hypertensive emergency. What else? What about the vasculature of the eye? We see what's called high-grade retinopathy. Now, the picture here, I hope you can see it, does not look like high-grade retinopathy to me. I don't know if it's supposed to, but what are the features of high-grade retinopathy are what we call retinal hemorrhages, where you see actual hemorrhages, and papilledema or papilledema. What is papilledema? That is a swelling of the optic nerve as it comes out on the retina, as viewed on the retina, and it's loss of distinct margins where you can see, here it looks clearly demarcated to me, but it becomes very blurred and hyperemic, very red, hyperemic in papilledema. And that means there's increased intracranial pressure, the optic nerve is swollen, and that is a marker for a hypertensive emergency as opposed to urgency. Other features are in the heart attack, pulmonary edema, heart failure, okay. And the other is loss of renal function, acute kidney injury, looking at the urinalysis to see if there are red cells in the urine, looking for acute damage, okay? And as I said, the creatinine. So acute kidney injury. Now, there is a diffuse vascular insult that occurs in hypertensive urgencies, and because there is damage to the endothelium, and we have what's called a microangiopathic hemolytic anemia. And if you are taking exams in the US, they always, I don't know, I worry that they always ask a question about microangiopathic hemolytic anemia, which means that you will see damaged red cells on the peripheral smear. That means helmet cells, schistocytes. You will see thrombocytopenia because of the vascular endothelial damage. And I think test creators like to ask that question. So that's called microangiopathic hemolytic anemia. With you need to look at the peripheral smear and so forth. I remember my teachers used to ask, "Did you look at the peripheral smear? Did you look at the smear?" Okay, so remember that. I don't know why LVH is there, but of course that's just like in the arteries. We see hypertensive heart disease. We see a stiff heart with a thick left ventricle, which is not pliable. And we see the end result of years of inadequately treated hypertension with a very thick heart, which is not distensible, and we have a high pressure system as a result. Now, hypertensive urgency and hypertensive emergency can be treated differently. We know that hypertensive urgency, that is high blood pressures without end organ evidence of end organ damage, can be treated bringing down the blood pressure over a day or two or 3 or 4, okay, with close monitoring. That people do not necessarily need to be hospitalized because the risk of acute events is low if there's no evidence of target organ damage with an honest search for it, okay? Many people, the most common reason that we see this is that people tend to not take all their drugs. They may have gone away and forgotten their medications, but that's very important. Also, people taking dietary indiscretions, where they suddenly go off a diet or taking a lot of salt, and their blood pressure will go up. Sudden changes in behavior. Medications, non-steroidals, taking a lot of non-steroidals will raise the blood pressure. If somebody's not completely controlled, they'll go over to 180, 190, okay? Now, if the rise is gradual, that's where it's just more of a hypertensive urgency. The patients may be asymptomatic, frequently are, okay? But if our blood pressure rises acutely and suddenly, that's more likely where you're going to get a situation of a hypertensive emergency, okay? So in that hypertensive emergency, a patient, that is an emergent situation where a patient needs to be monitored in an intensive care unit and probably needs intravenous medications to judiciously lower their blood pressure over the next few hours to a safer level, not necessarily to normal, but to a safer level. Because we know that the incidence of target organ damage, acute events, is fairly high in hypertensive emergency. Okay, does everybody understand that? Oh, I see a question.
Dr. David, can I ask a question?
Oh, please. Whoever it is, please ask.
Why do we need to decrease the blood pressure gradually? Why just not decrease it to the...
Because we have a situation where we have cerebral autoregulation, where people who, for over a period of time, okay, have had high blood pressure, their blood flow to the brain will remain constant, fairly constant over a fairly wide variety of blood pressures because of cerebral autoregulation, okay? And the body has adjusted to hypertension and the brain will be protected even if we're bringing down the blood pressure in hypertensive urgency over a few days. However, if there's a sudden increase for what reasons that we, I don't want to delineate here, but if there's a sudden increase with target organ damage, that cerebral autoregulation is not as embedded in a person, and that if we precipitously drop the blood pressure, their blood flow to the brain can drop, and we can actually cause some harm, causing a stroke or whatever from cerebral hypoperfusion if it's dropped suddenly. Okay, so we aim to drop it maybe by 20% or so over the first hour by using drips. Drips that we control. Oh, let me just see what's going on. Just a second. Excuse me. What is that? I'll ignore it. Okay. So anyway, sorry. So as I was saying, if you drop it precipitously, cerebral autoregulation is not embedded yet or as wide as a protective agent as in long-standing hypertension, and you could drop the blood pressure. Does everybody hear my doorbell? Did you guys hear that?
Yeah.
I think, let me just go to the door. I apologize. Okay, I don't know what, somebody just ran here. Excuse me. What? I don't know what that was. Some random person going to the door. I'm sorry. Okay. Honey, if you see a random person coming to your door, just tell
No,
them.
it's not coming to me now. By the way, Dr. David is...
Okay. Okay. So sorry. So anyway, that's why you could precipitously drop cerebral perfusion and actually cause a stroke. Okay. Does that answer your question? So
Yes.
they're graded. So that has happened, and people have learned from experience. There aren't a lot of randomized. This doesn't happen often enough that people can cooperate and form large trials to compare treatments and so forth. But it's generally known that when the blood pressure drops too rapidly, it's not a good thing. Okay. So you aim to drop it a certain amount, part of the way, and the target again is only 160 over 90, like within even a day, and then you start adding oral medications. Okay. So that's generally the treatment. But for the first hour or two, you try and bring it down to, close to 160 over 90. Okay, the first day. All right. What did I want to say? Now, the other thing with hypertensive, so let's say it's very important in hypertensive urgency or emergency to conclude or to determine that the reason for the elevation of the blood pressure is hypertension. It's not some other reason, like somebody's in pain after surgery, like somebody has urinary obstruction and their bladder's distended and they're very uncomfortable, or they have a broken bone and they're in pain, okay? Or they're post-operatively, you treat the pain. In other words, there could be other reasons for higher blood pressure than hypertension itself. Does everybody understand that? Okay, so that makes sense. You want to make sure it's, oh my God, this is, the patient stopped their medicines, their blood pressure is high, they have papilledema, Okay. All right, let's go on. Now, remember I said stage 1. Let's go back to stage 1. Did everybody see a slide change? Did the slide change?
No,
Yes,
yes.
yes, changes.
Or now
Okay.
that, now that.
Okay, so we see non-pharmacologic. So in stage 1, I said some people just need non-pharmacologic treatment and others need both antihypertensive drugs and non-pharmacologic treatment based on their cardiac risk, okay, based on all their risk factors. But let's go over non-pharmacologic treatment is always important. Whether or not they need medication or not, it's always important. And there are so many things that a patient has to do, it can be overwhelming. So we talk about weight loss. Now, I presume you people are very young. I just have the opinion that as you get older, it's tougher to lose weight. You're just not as active and so forth, but it requires discipline. It requires involvement with the patient. A change in diet. Remember the DASH diet? I guess I don't know if that's something you've studied, but dietary approaches to stop hypertension, and we see the picture on the lower right with fruits and vegetables and grains, and certainly not highly saturated fats and so forth are effective in lowering blood pressure. So that's the DASH diet: grains, fruits, vegetables, low in saturated fats, etc. Okay, is helpful. Obviously, reduction in sodium intake, easier said than done. Alcohol intake, I talked about that. As alcohol is being metabolized, stimulus for catecholamines, blood pressure is up. Tobacco, oh boy, that's tough. And trying to incorporate exercise or get involved. Now, how do you do all these things, okay? How do you do all these things? You remember, most patients feel well. Some of your patients will be skeptical. I feel fine, I'm healthy, I'm active. What are you talking about? Others will just say, tell me what to do and I'll do it. But I don't think those will be the majority. But I hope I'm wrong. And they will take to heart what you tell them or what you suggest to them. I think home blood pressure monitoring is very good to engage the patient and make them participants in this. This is a lifelong process. This is not a one-time deal, okay? So if such a thing is available, I would recommend it. Now, what is your relationship? What are you trying to accomplish with the patient? So this is where I think skill and learning and experience come in. That is not part of the guidelines, not part of the science. But even though it looks like there are rules and hard and fast rules, this is where the art comes in. Where can you develop a relationship with the patient where you are kind of a coach that is a motivator, that helps them to become motivated. Not saying you can do this, you have to do this, but can you be a listener? Can you say, how does this sound to you? What do you think? And getting their thoughts. This is a very kind of different kind of process. I don't know, but it's very, think about yourself. If you were learning all this, how would you like a person just telling you and hammering to you, or would you like to say, well, here's some things that help? What it would be really good? What do you think about this? Do you think you could try any of this? Would you be? And then the next time they say, well, I didn't do very well, you say, oh, what do you think the problems were? You're inquiring, you're bringing it out, so they're introspective. Do people understand that concept? Yes, no, okay. So you're a supportive coach. If you've been in a situation where you've been on a team or you've been in a class where the teacher was understanding, you will be aware of the difference. Okay.